Hello, everyone. Thanks for joining. So today's session, I wanted to sort of take a step back and kind of go through some introductory topics with strabismus. It's a complex topic, and while a lot of the tutorials that I'm going to give as part of the strabismus series will sort of cover specific pathologies, I think it's sometimes quite useful to just take a step back and think about how strabismus is assessed, what the different tests actually do, and also looking at how our orthoptic colleagues actually help us out. Um, so starting off with just sort of general definitions, you've got the phorias, which sort of talk about the deviations of the eyes. So orthophoria is essentially perfect alignment. So when you're doing a cover uncover, you don't see any movement. And that's actually quite uncommon. Heterophorias are where the eyes tend to deviate when fusion is blocked. So you won't necessarily see a manifest squint. And then when you come into the heterotropias, that's when you get the manifest deviations. So it's, for example, esotropias, exotropias, hypertropias, hypotropias. All of those talk about manifest deviations, whereas the phorias are latent deviations. A quick comment on angle kappa. This is usually about 5 degrees. Now, what the angle actually describes is essentially the angle between your fovea and the center of your posterior pole. So when looking directly straight ahead, your fovea should be about 5 degrees temporal to the center of the posterior pole, and that's the normal. And it can be negative, it can be positive, and a large angle can give the appearance of a squint. And you'll see this in things like retinopathy of prematurity, for example, where the macula can actually be displaced after treatment or from the pathology itself. And that's just a general sort of quick comment on that. Talking about extraocular muscles, I mean, most people watching this tutorial are going to, be well accustomed to how the muscles work and where they sit on the eye. But for your exams, it's always useful understanding what the primary action of a muscle is versus the secondary or tertiary actions. The spiral of Tillaux basically describes how close to the limbus your four recti are to the limbus. So the medial rectus is the closest, and then there's a spiral going clockwise with each of the recti being further away, or anti-clockwise, depending on which muscle you're looking at. So the medial rectus is the closest to the limbus at about 5.5 millimeters, then your inferior rectus, then your lateral, and then your superior rectus being furthest away from the limbus at about 7.5, 7.7, and these are sort of average figures. And the spiral of Tillaux is sort of clinically relevant when looking at strabismus surgery, in sort of knowing where the muscle should usually be sitting, and if it's not sitting there, has there been a previous operation or previous trauma, for example. The listing plane sort of describes, so if you're looking head on at the patient, there's a sort of plane that sits at the equator of the globe, and your eye sort of moves around this plane. So it sort of moves up and down, left and right, and it also cyclotorts around this plane. And then the axes of Fick are the axes around which the eye rotates. There's this quick drawing here that I've put in this diagram, which sort of describes where the muscles act most. So if you think about how your eye sits in the orbit, your muscles come in from the apex of that orbit. So your recti are coming in at about 23 degrees. So when the eye abducts 23 degrees, your recti are going to be acting at them sort of maximal actions, whereas your obliques will act maximally when the eyes are actually adducting. And that's at about 23 versus 51 degrees. So when you're looking at these orthoptic reports or in your exams, for example, if you want to know where the eye should be to see what the maximal action of your superior and inferior recti, for example, that would be 23 degrees abducted. Whereas if you're looking at your obliques, if you adduct the eye by 51 degrees, you're then going to see what the maximal action is there. And that's all about how the eyes, how the muscles actually sit on the globe. Your ocular movements, you've got ductions, which look at monocular movements, and you occlude one eye and you can test the duction of a single eye. Versions look at binocular conjugate movements. So you've got, for example, levoversion, dextroversion, that's all looking at left and right gaze. And your vergences are also binocular, but they're disjugate movements. So with the versions, it's, for example, looking up left or right or down, whereas your vergences are things like convergence, where the eyes are actually moving in opposite directions, but they're moving together. And then you've got the positions of gaze. So you've got your six cardinal positions, which actually look at, so these three and these three are your six cardinal positions of gaze. And then you add these three positions, so looking up, looking down, and primary gaze when it comes to the nine positions of gaze. But your six cardinal positions are actually up and to the left, up and to the right, looking to the right, looking to the left, and then down to the right and down to the left. Looking straight up, looking straight down, and the primary gaze are three additional positions when assessing the nine positions of gaze. The laws of ocular motility are important to sort of understand when you're looking at muscle sequelae and generally how the eyes move. So you've got agonist and antagonist pairs. These are pairs of muscles on the same eye and they move in opposite directions. Your synergists are also on the same eye. They move in the same direction. And your yoke muscles describe muscles on opposite eyes and they produce conjugate movements. You've then got Sherrington's law. So Sherrington's law describes an increase in innervation to one muscle causes a decrease of innervation in the antagonist of the same eye. Herring's law, so this is an innervation to one muscle gives you an equal innervation to the yoke muscle. So Sherrington's law describes a law of innervation within the same eye. Herring's law describes innervation of opposite eyes. And then your muscle sequelae generally when you're talking about underaction of a muscle. So when you've got the primary underaction of a muscle, the next thing that you're going to see will be overaction of your contralateral yoke muscle. And then what you'll see is an overaction of the ipsilateral antagonist and then secondary inhibition of your contralateral antagonist. Now, that can take a while for you to absorb and feel free to basically just go through that multiple times. And it's always useful to sort of look at specific examples when you're actually looking at how the muscle sequelae actually take place. So, for example, if you're looking at a specific paretic muscle, and then from that going on to actually see how things progress. So for example, if you wanted to look at a left superior oblique palsy, so your primary underaction would be the left superior oblique. You're then going to get overaction of the contralateral synergist, so that would be the right inferior rectus. So that is essentially what your Herring's law would do. And then you'll get overaction of the ipsilateral antagonist. So that would be your left inferior oblique. And that would be Sherrington's law. And then you'll have the secondary inhibition of the contralateral antagonist. And that would be both Herring's and Sherrington's law together. It takes a while to get your head around it. But essentially read through it multiple times and don't be surprised if you've not used it for a while, you forget it. I mean, that's, the thing with strabismus. It's quite complicated, and unless you're doing it every day, it can be quite easy to forget how these things actually work. You then have things like how a patient adapts to having a strabismus. So there are sensory ways of adapting. So either the visual cortex will just suppress one of the eyes, and that can lead to amblyopia. You can then end up with abnormal retinal correspondence, for example, where actually non-corresponding parts of the retina then decide to correspond. And you can also end up with something like a microtropia, which is a separate pathology in and of itself. Or you have motor adaptations. So the patient can adopt a face turn, a head tilt, or chin elevation and depression in response to problems with diplopia. Assessing strabismus is really complex, and there's lots of different things that we're looking at when we're looking at a patient who comes in with diplopia or strabismus, and that's where our orthoptic colleagues are essential, really, in strabismus clinics. And you're going to be looking at things like the history, the visual acuity of the patient, how much stereopsis they have, how much binocular fusion they've got, do they have any sensory anomalies, measure the deviation itself, looking at motility testing. We'll talk about the orthoptic report as well. Then you're going to look at fields of BSV, Hess charts, and very importantly at the end, also the refraction of the patient, which is essential, especially when looking at children. So when thinking about the history of strabismus, you're going to ask things like, was this present from birth? Is it new? Has it been, was it within the first 6 months of childhood? Was it later down the line? How long have they had the deviation for? And generally, the later the onset, the more likely there is going to be an accommodative component. Then ask for things like symptoms. Are they actually diplopic? And actually, if patients are symptomatic, generally that actually suggests a decompensation of a previous phoria, or for example, a new new paretic muscle. Is there a variability? Is it intermittent? Does it alternate between the two eyes? Do they have a refractive error? Do they have any ocular pathology? What's their general health like? For example, patients with cerebral palsy typically do present with strabismus. What was their pregnancy like? What was the birth of the child like? Is there a family history of strabismus as well? And all of these things are important to elicit from the patient or from the patient's parents when seeing a new patient coming in with strabismus. Then look at visual acuity. So in pre-verbal children, you'll look at things like how they fix and follow. Do they have a preference of using one eye? If you cover one eye, are they more upset if you cover the left or right? 10 prism diopter testing can be helpful in separating the two eyes. Do they have preferential looking? And VEPs can also be useful here as well. So if you're watching this online on the playlist, I talk about VEPs when discussing EDTs. And in verbal children, you can either use K pictures in children who can't yet read but can kind of describe pictures versus logomar in older children. A measurement of stereopsis. So this is a measurement of a patient's abilities to essentially see in 3D, and it's measured in seconds of arc. So a single degree is 60 minutes of arc, and obviously a minute of arc is then 60 seconds. And there are multiple tests, and this is a common area of testing when it comes to your, for example, the part one written or the part two written exams. So the Titmus test, I always remember this as the litmus. So this has the largest range of testing. So this all the way down from 40 up to 3000 seconds of arc. And you've got this picture here in the top left, looking at the fly, the animals and the circles going up in degrees. The TNO test, you've got these 7 plates with red and green dots and red and green glasses. The Frisbee test, there's this test here in the bottom right where you've got these multiple different shapes and you'll have hidden circles within them, and one of them will have a circle, and that goes down on your seconds of arc. And then the Lang test will have a shape amongst a whole bunch of dots. And then if you see that shape in 3D, different cards will give you a different level of stereopsis. Binocular fusion, so you're looking at the ability of the eyes to see together. This is typically tested with a base out 20 20 diopter base out prism over one eye. And this diagram sort of shows what happens. So if you put a 20 diopter prism out test on the left eye, what will happen is that left eye will move. The right eye then moves a lot and then comes back to try and fuse the two eyes. And that's what will happen in the normal eye. Most can overcome a 20 diopter base out prism, but sometimes you may need to use smaller prisms for patients with lower fusion ranges, and that can give you an understanding of how much fusion a patient has. And then a binocular convergence, this is literally just following an object down to the nose, and usually a child should be able to do that from 3 to 4 months. And if they're unable to, either they're just disinterested, or there is a problem with their convergence. Then you've got things like sensory anomalies. So this is about suppression of one eye versus, for example, diplopias as well. So with the Worth 4-dot test, you've got a green filter over the right eye and a red filter over the left. And then you're basically asking how many dots the patient can see. So either they're going to be suppressing, or they're going to have binocular single vision, or they're also going to have problems with or abnormal retinal correspondence. So these images at the top will describe what the patient can see. So either they can see 4 dots, and that's normal. If they can only see 2 red dots, that means they're not being able to look through their right eye. Whereas if they can see the three green dots, then they're not looking out of their left. And D and E sort of essentially describe esotropias and exotropias, where you can see all five lights. Then you've got the Bagolini striated glasses, and this picture at the bottom sort of describes what's going to happen here. So you've got oblique lines seeing through tilted lenses, and a normal patient should be able to see both lines crossing over in the middle. If they have scotomas, or if they have esotropias or exotropias or suppressions, for example, you're going to get different lines. So a scotoma where you'll have a part of the line missing. Esotropias and exotropias, you'll see both lines, but they won't cross in the middle. And then suppressions, one of the lines will essentially be missing. A four-prism base-out test, this is very similar to the 20 prism. It's basically done in the same way, and it tests for veal suppression. And And the way that works is because it's a very, very small amount of movement. If you have any suppression within that central foveal field, then you can test for that with the four-prism diopter, and that's useful for microtropias. And then the synoptophore is a quite an involved test, but it can help look at different sensory anomalies, and it's also quite useful because it can also include looking at things like cyclotorsions as well. Then the meat of the discussion when it comes to looking at strabismus is how do you measure deviation? So there's lots of different ways to do this. And the point of this is that it's an introductory talk. I'm not going to go into the intense specifics, but your Hirschberg test is essentially looking at your light reflexes on your cornea. The Krimsky test is looking at this plus using prisms to then try and get that reflection on the same part, and that can, calculate that deviation a bit more objectively. You've got the cover uncover test, the alternate cover test, the prism cover test using prisms to actually look at the amount of deviation, and then the Maddox wings and rods, and then specifically with the Maddox rod, double rods can be used to determine cyclodeviations. And this is, going to be what your orthoptic colleague is going to be doing, and what you may also be repeating in the clinic when it comes to trying to see what the problem is with these patients. So with the Hirschberg test, that's a really quick, easy test that you can do. The cover uncover test. So your cover test is essentially going to detect a heterotropia first, and then the uncover test is where you detect a heterophoria. So uh, that's how the two work together. And then the prism cover test works very similar, but with a prism attached. Your motility testing, you're going to look at versions and ductions, and then what your orthoptic colleague is going to give you is a numerical score for underactions from -1 to -4. -4 is essentially no movement across the midline, down to -1. That's usually a proportion of how much movement. So for example, 25, 50, or 75% of the expected movement. And importantly, what can be useful here is post-operative diplopia testing. So you can essentially test for potential diplopia by putting a prism above the eye to try and make up for what surgery you're going to do. So you can put a 20 or a 30 or a 45 prism over the eye and see whether or not the patient then develops diplopia by moving the eye in a specific direction to mimic the surgery that you're going to do. And if they do develop diplopia, then you're a bit worried that surgery may not be the best idea for the patient. And what you can then do is essentially give the patient some Botox to see whether or not they develop diplopia, because the Botox would be temporary. And if they do develop diplopia, then you're essentially telling the patient that actually surgery may not be in their best interest. So talking about the orthoptic report, some of you, in the feedback have said, you want to sort of go through this. Now, the resource that I used when I was trying to get my head around this was the orthoptic report. What does it all mean? It's a report by Laura Darley. It can be found on inews.uk. And you can go to that and you can read that in more detail. And this is a really, really good sort of run through as to how it works. So for example, you'll have the cover test, which looks at phorias and tropias, like I said. That will be a near, and that will be for distance. And that describes here that you've got a right hypertropia, for example. Then your ocular movements, and you can see here, so you've got a +2 overaction, you've got some -3, which gives you the underaction. And then you can look at the convergence, the Bagolini glasses, and then here you've got the prism cover test. So what this tells you is that in near there's a 25 base down in the right eye, and then in the distance there's 18. And then in the 9 positions of gaze, what this tells you is that deviation is largest when looking down to the left and smallest when looking up to the right. And then it goes on. So you've got a moderate alternating exotropia. Then you're looking at these vertical lines, so do you have an A pattern? Do you have a V pattern, which tells you do here, you've got a V pattern. And then the Bagolini test with glasses, again, looking at whether or not you've got a BSV response, or do they have a suppression. Then your Frisbee test, how many seconds of arc do they have? And this is, if you go through, this is the sort of the formal orthoptic report that you'll go through. So if you in your own time go to this report on inews.uk.com and go through it, I think it's a really good resource to sort of go through what the orthoptic report actually involves, and what the sort of formal report based on the British and Irish Orthoptic Society guidelines are. Then you've got binocular single vision. So usually you've got Goldman perimetry. This gives repeatable measurements of BSV. So it's quite handy in having a repeatable measure in clinic in patients with um, uh, chronic sort of follow-up. And this bit in the middle tells you where they've got the binocular single vision. And then on the outside here, this is a normal test. And then you can look up in your own time what things look like for specific pathologies. And then when we go through these specific pathologies, we'll also bring them up in those tutorials. The Hess chart, the way that this is done is you essentially put, so for example, when you're testing the eyes, you're testing the non-fixing eye, the non-fixating eye. So each square represents 5 degrees, and when you're fixating with your right eye, for example, there'll be a green light. You have a green light, you've got a green laser, and then a red light will appear. And then the patient is asked to shine the green light onto it, and the movements of the non-fixating eye are then looked at. And the way you interpret it is that when you're looking at both fields, the smaller field is usually the one that is the problematic one that will have the paretic muscle. The larger field is where you can see your overacting muscles. And the things to bear in mind with the Hess charts is that they're not very good at looking at cyclotorsions, which is where the synoptophore can be really helpful. Now, lastly, the refraction and the fundoscopy. This is key when assessing strabismus, especially in children. And most commonly, you'll come across hypermetropias in patients with strabismus, especially in kids. And you have to do cyclopedia, especially when looking at hypermetropia, because they can mask some of their hypermetropia by accommodating. So you need to give them some cycloplegia to remove that accommodative masking to see how much hypermetropia they have. And then a common question that comes across from the junior registrars when you're in clinic is, when do you actually start to think about prescribing glasses? So if the patient is hypermetropic, you usually don't really need to correct this up to about 4 diopters of hypermetropia, because young kids are normally hypermetropic. And then as they get older, as the eye gets bigger, that hypermetropia tends to resolve. So unless it's more than 4 diopters, you generally don't need to correct it unless they have a squint or if they've got near vision problems. And then if you are going to correct it, usually you'll give about 2/3 of the correction that's given. But if they have an esotropia, then you'll correct it fully. Then in patients who have an astigmatism, usually if they've got anything more than about 1.5 diopters of CIL, then you'll correct it. Myopics don't tend to be corrected unless it's more than about 5 diopters in young children under 2. If they're between 2 and 4, if it's anything up to about 3, more than about 3 diopters, then you'll correct it. And then the older the child, the more you'll correct even the lower grades of myopia. And then with anisos, essentially, if you're over 3 years old, you really should be having a full correction of anisometropia if it's over 1 diopters of difference between the two. So if you've got a 1.5 diopter difference between the two eyes, then you really should be correcting for that in children of above 3. Fundoscopy is also essential because you've got a lot of pathology that can then contribute to sensory exos or sensory esos. So making sure that you have a fundoscopic exam in patients with strabismus. Um, and refraction and fundoscopy tends to happen on an annual basis for patients with strabismus if they're coming into your clinic. So in summary, just kind of as an introductory talk of strabismus, it's a very complex assessment, and there's lots of things that you can think about doing in these children when they're first being referred into your clinics. And so if you're, if you're in a strabismus clinic, this is a run through of the different things that will happen and why they're useful. You're working very closely with your orthoptic colleagues, and it's really worth taking some time in understanding what their report means, and actually perhaps even sitting with them to see what they do, because they sort of, without them, a strabismus clinic suddenly becomes incredibly difficult. And having a good understanding of what the normal movements are and what the assessments actually show and what the different assessments show is really quite key in then understanding what type of strabismus you're looking at, and therefore what intervention you're going to offer to these patients. And different tutorials when we're looking at, I've got the tutorial on ESOs and EXOs, looking at how those different deviations are actually managed. So thanks for joining. This is just just a reminder, please, to fill out the feedback. And I hope you kind of found this useful. It was just a sort of introductory session on strabismus and the assessments that are involved in approaching a patient with strabismus. And then the other tutorials sort of go into the specific pathologies. So thanks for joining, and we'll see you at the next one.